I mean, I get it. I work in an ER, so I work in hospitality, hospital, healthcare. Anytime you do any kind of people job, you get all the crazies. End of story. Like, there's no way around that. The sad, the sad part is, like, people like that, like, when you call the cops on them, you know what they do? They bring them to us because they don't want a paperwork of booking them into jail. So we get all these people that legit don't even need to be here for any, like, they're not here for any kind of medical reason. It's because the cops don't want to do the paperwork. Yeah, yeah, we get that. Like, people, people that are drunk or like high on weed or something, some rando on the street will like call the cops on them because they're either A, worried that, they're gonna flip out, or B, it's like they're just concerned about them, and it's like they're not in a right mind to refuse anything, and so like the cops will be like, I don't want to deal with this. Just take them to the ER. They can't refuse because they're not in the right mind. They're drunk or they're high. They'll just straight up bring them to us when they don't need to be here, and they're like, what are we gonna do with them? They're just drunk. Let them just work it out. Or they're just high. Just let it run out of their system, man. Oh, so it's complicated, right? Um, and that's that's primarily because it's the U.S. healthcare system, right? It's overly complicated. When you come in, from the minute you come in to when you're seen by a doctor, or in many cases now either a PA or a nurse practitioner, they are seeing an increase in use because of just the length of time it takes. The target is supposed to be around 30 minutes for when you check in to when you are seen by a provider, whether it's a doctor, PA, or NP. That is the target. ERs are only so big, like the one I work at. It's the largest in my region. It's got like 60 beds it can hold, roughly speaking, 60 beds, and like a lounge area where if like you're just here waiting on like an x-ray because you dropped a hammer on your toe and now you can't walk on your big toe, we'll do the x-ray in the room, have the doctor see you, and then we'll put you in like a lounge area where you're just waiting for the x-ray results. Oh, so at night, because we have like reduced staff, right? So even if we have like open rooms, there are staff ratios um, where it is unsafe for a nurse to have more than four patients at a time. And that's like super max. Like typically we prefer to have three patients. We can do four. Once we get that fourth patient, all of our workload immediately slows down because like we're dealing with people that could be septic, we're dealing with people that could be having a heart attack or a stroke, and oftentimes we'll get all of that together. And so the amount of work that we have to do exponentially increases, and our ability to handle more patients in a shorter amount of time now becomes very reduced, right? So if we only have three patients, we can typically handle it rather easily without issue. Once we get that fourth patient, I don't know what it is, right? But that fourth patient we immediately have like a huge slowdown in our ability to do work faster. And it's because we now have more stuff to do and more things end up taking priority, which puts other people down on the list. And so when you have like a longer time to basically get stuff done, people end up waiting longer out in the lobby when they check in. We don't get to see them fast enough. There's also like staffing concerns because we have less people at night typically. Less people, less amount of patients we can handle at any given time. Like most of the time at night now, from like 11 to 7 in the morning, if it's a busy night, we'll all have four patients. There'll be like six of us, all with four patients. And if it's a 60 bed ER, like what we are, I mean, we're not even at half capacity because we're all taking about four patients That's only 24 patients that we can see at one time. I can tell you like the target, right? So target from when you check in to when you're seen by a provider is 30 minutes. Um, if you are, so like we have what are called triage levels or ESI levels as they're called in the US. Um, ESI levels of like 4 to 5. So those are like your very simple cases. So they're going to be, so like an ESI level of 5 would basically be you ran out of blood pressure meds, you no longer have a your prescription for a blood pressure med is expired. You can't get into your doctor's office, let's say, until like 2 days from now, right? You come in, you're an ESI level of 5, you're pretty basic. All you need is a prescription by any provider that can see you and say, yeah, your blood pressure is high. Here's a script. Go to the pharmacy, fill it. Door to discharge is 1 hour to 90 minutes, right? Max 90 minutes. We try. National target is supposed to be 90 minutes, if I recall correctly. Our like facility target is 1 hour. Very simple process. You come in, you're checked in, you get a set of vital signs. When you come in, you see the doctor or the nurse practitioner or the PA. Here's your script for the blood pressure med. We take another set of vitals and then we kick you out, right? That's door to discharge, supposed to be between 60 and 90 minutes max. That's going to be your ESI level 5, so your lowest acuity. ESI level 4, something simple, right? You just are like follow up rabies vaccination, right? All that is one shot and you're gone. So that's going to be like a 2 hour target wait because we have to get the rabies vaccination from the pharmacy in our hospital because that stuff is kept in cold storage. ESI level 3s, you tend to get more complicated stuff. So these could be, let's say, like a 20 or 30-year-old that got like rear-ended, nothing really going on. They're just here because they're sore all over, right? So fender bender at a stoplight or a stop sign. Those are basically going to be your ESI level 3s. If they're older, so let's say like they're a 60 or 70-year-old, they're going to be your number 2. So they're going to be more important because when you get older, you typically will have more complications, right? So this is where things start to get a little difficult when it comes to times in how long you're going to be in an ER. Target, if I remember correctly, so this is like national target time of ESI level 3 is 4 hours. And that's if they're going to be discharged or admitted. So door to what's called disposition, that's discharge or admission. Door to disposition is supposed to be 4 hours. Things get very fuzzy because typically for a disposition, we're waiting on other things. So let's say, a 60-year-old comes in, right? They're at stop sign, they're hit, fender bender, very simple. Car is totally fine other than a small dent you can buff out. But insurance says, hey, you need to be checked out by an ER in order for us to approve anything, right? So they come to the ER, they get checked out. We know they're fine. Vitals are fine. They have very few problems. Most old people have like high cholesterol, high blood pressure, very normal. That's all they have. That's all they take stuff for, right? They're going to be like an ESI level 2 because of their age primarily. And all we're basically going to be waiting on are results of a CAT scan. We could be very busy and we have CAT scans that are backed up, like the radiology doctor is very backed up. It could take like 4 or 5 hours for them to finally get the CAT scan results back. But we could have known like they're going to be discharged in like an hour and a half. But because we're waiting on all of those radiology results, it could take a while. Same thing with like being admitted upstairs. Like we could be waiting on something from the admission doctor. So like the ER doctor could be like, yeah, you really are sick. You're septic. You've got an infection. Like let's say you come in with like nausea, vomiting. It really hurts to pee. The doctor's like, yeah, you got a UTI. You're septic. That's causing all these issues. You need to be admitted for like IV antibiotics for the next 2 days, right? Well, the admitting physician, which is a different doctor than the ER doctor, could be like, I don't really think they need to be admitted. but just to double check, run this test, run that test. So now we're waiting on all of that, right? So there's like all of these extra factors that come into play. Target is typically going to be like 4-ish hours for like your really severe cases that aren't a level 1. Like an ESI level 1, you're automatically being admitted, end of story. But like your 2s and 3s have the potential to be discharged. A lot of it is dependent on like we're just waiting around for stuff. And when it comes to like any kind of people service, it just takes time. It really takes time. Like there's no way around that, sadly. So it's not unusual to be waiting in the ER for something for like 6-8 hours, sadly. And it can sometimes take even longer. So with day shift, it's a little bit faster because you have more people here. You have more people working, you have more nurses, so that means they can see a max amount more than night shift. You're going to have more departments opened up, things are just going to be run faster. For our location specifically, our radiology doctors aren't on site at night. So we don't have rad doctors here at night. We send all of our studies electronically down to like the downtown area in the, it's not like the capital, but it's a pretty large hub city down south. That's where we send all of our stuff at. So they're getting studies from all over the region, all over at night. And so they are always automatically backed up. It can usually take 2 to 3 hours for any like CT to come back. Like that's just that's just unquestionable. During the day, we have radiology doctors here on site. So it's easier. It's easier during the day. We have people, we have staff, things just get done. At night, oh, wow, that was powerful. At night, we lose staff throughout the evening. We don't have departments open. So you end up waiting long. It's really unfortunate, and that that sort of comes into play with something called HCAPS. I don't know if you ever heard of it. HCAPS is a survey that's sent out to everyone like 4 to 6 weeks after their hospital visit. Consistently, the ER overnight is rated the worst because things just take longer, and it's really frustrating, and it really sucks. But yeah, typically during the day, things are going to be faster. Yeah. So you're not the first person to kind of relate to me the degradation in like wait times and overall care quality. I honestly can't give you a definite reason for that. There are like some of the older nurses that have been around that I talked to from before like the Obamacare era do say that things were better before. After like around 2011, 2012 is when Obamacare, the Affordable Health Care Act, was signed into law. I believe, like, I don't know, like, I didn't really have much experience with healthcare before then, so I can't give like my own like experience in seeing that degradation. I can tell you some changes have been better versus worse over the past like 5, 6 years. Anyways, I honestly can't give you a good reason why that was the case, other than potentially Obamacare stipulated certain things to the insurance companies in what they required for someone's care to be covered, and to get like some kind of kickback from the federal government, like Medicare, Medicaid, stuff like that. That's the only thing I can think of. I don't know, like, personally. So I wish I could give you some kind of inkling, There's a really good individual on YouTube. His name is Dr. Glaucomflecken. He does a lot of videos. They're in like a funny satirical manner of how kind of scuffed up the U.S. healthcare insurance system is. And it's funny that he's doing that because it's stuff that a lot of people, at least I have personally been feeling for like the past several years that I've been in healthcare. To give you like what is basically the Cliff Notes version, in the US, health insurance companies effectively function as doctors, right? They can basically tell whether it's a doctor's office, an imaging center, mostly them. When you come in through the ER, you have a lot more liberty. There are some things that have to be discussed with the insurance company when you're admitted as an inpatient that do require approval by the insurance company, but it mostly pertains to like outpatient stuff. So outside the hospital. The insurance companies can, in effect, dictate what is covered under their policies. That's why there's things like pre-authorization, pre-approval. Basically, the insurance company has to approve the use of your insurance policy that you're actively paying for. And it really sucks because it does leave a lot of people effectively, I don't want to say like left to die, but that's effectively how I feel about it. Which is why ER services end up getting overused. So in the ER, we see literally everything, from like strokes and heart attacks and motor vehicle collisions, gunshot wounds, knife wounds, trauma, to the stuff that can and should be managed by a primary care. So that's going to be like your regular doctor that you would go see if you have like a cold or something, right? Which we get a lot of. We get a lot of people that just don't have insurance or carry it, or they do carry it, but using it is so expensive or adverse to anything beyond like a major life-altering event, that they just come to us for the normal things. And so we end up being like the safety net for people as well. So it really sucks all over. And that could have like some effect on like the increase in wait times. Probably especially after Trump effectively de-gutted Obamacare, because a lot of people with the Affordable Health Care Act and the Supreme Court upholding the federal government's right to effectively place a burden tax on people who don't have health insurance, people had to carry it. Problem is, a lot of the times, like if you went on the exchange marketplace, a lot of the insurances were either more expensive than just paying the fine for not having insurance, or B, so useless it was just like there was literally no point. Like it was like, so people just literally just wouldn't even get it. And so you ended up having a lot of that, and that I think ended up placing a large burden on the ER. It is unfortunately a known phenomenon, and it's just the unfortunate reality that we live in. But like I can't give you like a definite reason why things are so terrible. It's more like a nickel and diming thing, right? Death by 1,000 cuts.